Hello, Vancouver Coastal Health. Welcome to our first edition of Coffee with Infection Prevention and Control. Your host today will be
Dr. Andrew Hurlbert.
And Amira Imamovich Bulubasic, registered nurse, infection prevention and control practitioner. So we will let you know a few things about what infection control team will be doing. But first of all, let's do some housekeeping stuff. For really positive learning, let's do video turn off, please. Microphones on mute. Question, please submit them to the mentee and we will answer them as soon as the presentation is done. And don't forget evaluation at the end of the session. Our mentee code is on each slide and right now is 758323. So infection prevention and control team, I'm hoping that all of you already know who the parts of infection prevention control teams are. But if not, just a reminder, medical microbiologists and infection prevention and control nurses are the team that usually is a part of the infection prevention and control department. We do work Monday to Friday, 8 to 4. However, evenings, weekends, holidays, coverage is provided by MedIPAC and microbiology on call. So pretty much every day, 24/7, you can have access to infection prevention and control. On hours are mostly infection control nurses that will take your calls or questions, and any urgent issue can be always run by med microbiologist or call by dialing 0 and asking for med micro on call.
Just as a note, I'm actually from infectious disease, not med micro, and you may talk to me on the phone, so don't be confused.
Okay, so today's topic will be personal protective equipment or PPEs. We'll speak about routine practices first of all, then we will move towards additional precaution. We'll talk about different PPEs that are out there nowadays, and we will be covering specific infection control personal protective equipment for COVID patients. Routine practices is something that we are expecting every staff to do at any time for every patient. And those are your point of care risk assessment. We are really hoping that you all are assessing any patient client that you see for any risk for any infectious diseases. Let's give you an example. You have a patient that is coming in with a broken hip, but you notice that patient is having moist cough. Then what you would do is give really your patient surgical mask so that you ensure that he does not spread anything around. You put droplet contact precaution on yourself. Then you assess patient and see if there is any further concerns. Alert physician, and on top of dealing with the broken hip, you will be dealing with somebody that might have some respiratory issues because you just did your point of care risk assessment and you have been protecting yourself, your colleagues, and your patient in an adequate way.
So just to add, I think that this is probably one of the least talked about and most important aspects of infection control. We in infection control are not the gatekeepers for PPE, and there are always exceptions compared to what's on the door as far as signage. And this part is really important to make sure that every situation is different and situations can change. And so the point of care risk assessment really is your first and probably best line of defense from an infection control perspective, but high-end hygiene aside.
Yes. And always remember as well, we isolate people when we are suspecting something or knowing that they have something. But a lot of people are walking and talking and seeing us and they might have something. So your point of care risk assessment is really important to protect yourself and others. Having said that, we will move now to additional precaution. As you know, there are 6 different types of additional precautions. Signages are up on a screen, and those signages are accepted across BC. So if people are working in a different health authorities, they should be having by now all the same signages. We won't be talking about every single one of those, but it's always really good to remember that those signages are there for a reason. Take a look at them. If you are not, they will tell you what to do as a healthcare workers. They will tell families and visitors what they are supposed to do. And at the back side of all those signages are really a couple of examples which sign you will use for which type of infection. Moving along, contact precaution. For contact precaution, you really need a gown, gloves, and you need to perform hand hygiene. Performing hand hygiene for contact precaution could be with alcohol-based hand sanitizer, or it could be done by soap and water. Contact plus or a GI precaution are slightly different, and that's why we have the slide up as well. Just because on top of a gown and a gloves, we are really recommending hygiene to be done for GI, any GI diseases or infections with the soap and water. Main reason is when people are having diarrhea and they are having some GI going on, until we really know what it is, we will not be knowing what type of organism we might be having. C. difficile lives in the spores. As we all know, it really needs that friction that we use while washing our hands and rinsing of the water to remove the spores from the hands, rather than killing them by anything else. So that is why this is the only type of precaution in which we would prefer staff using soap and water on top of alcohol-based hand sanitizer. For anything else, either or is good enough. Droplet contact precautions on the top of the gown and the gloves. We are adding now mask with the visor for that droplet piece of. And as you know, we are seeing a lot of masks right now with a lot of visors as well, and a lot of different types of eye protection. So the bottom line, anytime you deal with somebody that has a droplet contact precaution, you do need to cover your mouth with some type of mask and have something that is protecting your eyes. Airborne contact precaution on the top of gown and the gloves, which is part of your contact precaution, we will be adding N95 mask. N95 mask is very specific for every person, and everybody has to ensure that they are tested on a regular basis and fit tested by workplace health. Hand hygiene, of course, with any of those precautions is before you put a PPEs on and on a doffing in between each step. Please ensure you do clean your hands before you put the gloves on, as well as after you take your gloves off.
Okay. So, I guess, fine. So, I guess I'm healthy. So, the next section that we wanted to go through was what is different in COVID compared to our regular practices, because most people are familiar with seeing the regular signs for contact, droplet contact, etc. Whether they've been following them to the T or not before is a separate question. But I think there have been some changes in COVID, and our goal is to try and clear up the confusion by providing a little bit of context. So normally, we would treat COVID and infections like it similar to influenza, in the sense that we would typically require droplet and contact precautions to try and avoid transmission and to prevent transmission from respiratory droplets and from fomites or potentially contaminated surfaces in the vicinity of a patient. Now, when we look at droplets, these are large droplets that typically don't go beyond 2 meters, which is where that 2 meters comes from. When we're looking at things like social distancing, that's where that comes from. But there have been some changes on top of these basic precautions. The first of which was a Ministry of Health direction that made or basically instituted a recommendation to use a mask and eye protection as well as gloves for all patient care, regardless of whether they were COVID positive or COVID negative or symptomatic or asymptomatic. This is why we're making the recommendation to continue wearing a mask and eye protection as well as gloves for every patient interaction. Well, can we go back a couple, please? Yeah. Thanks. I think the other key point here is there's been a second modification that has changed things a little bit. and that is the extended use of PPE. So in addition to wearing a mask and eye protection and gloves for every patient contact, things have changed to allow people to use PPE for longer in ways that are still safe in order to decrease the demand of PPE supplies. So, for example, normally, even with the provincial recommendation, any patient interaction would involve putting on eye protection, putting on a mask, putting on gloves, doing patient care, performing hand hygiene as you doff, and you would doff all pieces of equipment. And if you were to have a subsequent patient interaction, you would put everything on again, engage in your patient interaction, and then doff everything. Now, in that sort of a setting, you would be using a whole lot of eye protection and a whole lot of masks. And so we have implemented a series of recommendations for people to be able to continue wearing the mask between patient interactions in order to limit the number of masks that we would have to use per day. This results in people wearing the masks and eye protection in the nursing stations and in areas outside of direct patient contact. This is the reason why this is happening. A key point is that the gloves are still to be used only for each individual patient interaction. That is to say, you don gloves, you perform direct care, and then you doff that set of gloves and you throw them out, and you use a new pair of gloves for each patient. Okay. So, we wanted to now go through a couple of items that might be new or different that you're seeing around the hospital, just to give people a bit of familiarity with what the various pieces of PPE we're using are and why we're using them. So for COVID positive or COVID suspected patients, we are recommending the use of droplet contact precautions and or airborne precautions in certain situations. So of the list you see here, you'll note that the surgical and procedural mask, the eye protection, the gown, and the gloves are all part of your standard droplet contact precautions. The N95 mask we will talk about a little bit more going forward. But this is the standard that we would look to use in patients that we either suspect are COVID positive that have been swabbed and whose result is not back yet, and patients who have been swab negative, but there's still suspicion that there might be COVID positivity, or for any influenza-like illness that is not yet diagnosed or tested. When we look at the procedural mask and the surgical mask, this is actually a piece of technology. I know it looks like paper attached to some elastic bands that you throw around your ears, but this has actually got a ton of research in it and a lot of very actually in-depth industrial science behind it. These masks have a very high filter efficiency and have actually improved, probably doubled in efficacy and efficiency of that filter, even since 2003 and 2004. That aside, when you're using them, you put it on at the beginning of your shift and you can keep it on between patients and then change it if it becomes soiled, if it becomes damp, or if it becomes damaged, or if one of the earpieces break. You can also change it if you're going on break, if you're going for lunch, if you're leaving at the end of the day. And when you take it off, that stays off. Once it is off, it goes in the garbage and you don a new mask when you're ready to resume and are going to be starting patient care again. As far as touching the mask, please try to avoid this as best you can. We as human beings love to touch our faces and it happens completely subconsciously. If you do touch your mask, there's no need to throw the mask out. Simply perform hand hygiene before touching anything else. So we wanted to get into this a little bit because the term AGMP has become part of the familiar vocabulary all throughout Vancouver Coastal Health. And I'm pretty sure about a month ago, nobody had the faintest idea of what an AGMP was. So AGMP, as many of us know, stands for Aerosol Generating Medical Procedure. What this is a category of loosely defined activities that cause or are of a higher risk for generating very small particles that can linger in the air and which can go longer distances, and which are so small that the surgical mask, although it would provide very good protection, may not provide the highest degree of protection from inhaling those small particles. Examples of this are things like intubations, extubations, use of the BiPAP mask, and the high flow oxygen right now. All AGMPs are not created equal, but when we talk about AGMPs and the use of PPE, this is what we're referring to, and you can make the association of AGMP equals N95 or equivalent. So in COVID, we are using this in places like the ICUs where people are on ventilators. If people are getting intubated and extubated, we're talking about eye protection. Nope, no, not yet. Thank you. And what we're looking to do is this is what the AGMP means. When we are looking at doing AGMPs in COVID specifically, it's your droplet and contact precautions. So your eye protection, your gown, and your gloves, with the addition of an N95 mask for that particular portion of patient care. Eye protection. This can be an annoyance. I totally understand. However, there is some pretty good data to show that eye protection is an independent protective factor from transmission of coronaviruses, and most of this data comes from SARS. So your eye protection is actually pretty valuable. When we look at there are many different kinds of eye protection. So there are goggles, there are masks, there are the face shields, there are the masks with the visors, and then there are safety glasses. If you have any questions as to whether your eye protection is satisfactory and meets the IPAC requirements, please contact us and we would be happy to advise you. The general gist is you want to have something with a large surface area to block splash from getting in your eyes. And most reading glasses or prescription glasses are not adequate. What you'll see is now, because we are trying to conserve PPE, we are looking to reuse eye protection and we're cleaning it with disinfection after we use it and before we put it back on again. This can happen during your shift, at the end of your shift, between shifts. Basically, anytime you take off the eye protection, you should be looking to clean it, and you can clean it with cabbie wipes or wash it with soap and water. Gloves. Everyone should have probably used gloves at some point during their training or during their job, I'm sure. If not, that is completely okay. The key point about gloves is the gloves are not 100% protective. Gloves do not allow you to forego hand hygiene before or after. The gloves act as a barrier to take most of any sort of bacteria or contaminated substance and block the majority of it to stop it from getting on your hands. It may not block 100%. This is why we say wash your hands before you put the gloves on and wash the hands after you take them off. This is also why the gloves themselves, you can think they can be quite dirty. So we don't want people to take the gloves and to take them into the nursing station and use them on the computer, or to use the gloves and open the doors. This one, we don't want to take used gloves and do that. And two, using gloves, new gloves, when we're looking at using computers, door handles, etc., does not substitute for hand hygiene and may give people a false sense of security. It also is not clear for anyone else when you put those gloves on. So we're really strongly recommending that to maintain consistency and make sure everyone's okay, to not wear gloves in those common areas. Gowns. So I guess we're not really talking about scrubs here. We'll go quick. So the gowns are basically to stop from splashes from getting through. All the gowns that we have here are rated strong enough to prevent COVID from going through, and most of them are reusable. We have had a few companies nearby provide us with gowns which will look a little bit different. And so you see some pictures, particularly the one on the top left, of a new gown that is, I believe, in circulation right now, which may look unlike the gowns you've seen before. The important part here is please do not throw these cloth gowns out. They can go in a laundry hamper where they will be washed, and the washing is sufficient to prevent any particles or virus from transferring on to subsequent use.
So all information that we have provided you are available as well and much more on Infection Prevention Control website, which is ipac.vch.ca. This presentation as well, together with all the questions that have been answered today or a question that came through and we didn't have a chance to answer, they will be all posted on our IPAC website in the next 24 hours. So now we will take some questions, and I can take the first one because I had a chance to have a quick break. So mental health patient who leave on pass and return, should they be quarantined for 10 to 14 days? Should they have NP swab done initially or only if they are symptomatic? We do not screen patients unless we have a reason to believe that they could have something, including COVID. So in this case, answer is no. Patient leave on a pass, especially mental health patients, and they come back. They sometimes just go down to buy smokes and they come back. They are not a type of patient that we will be putting in a quarantine or doing anything further unless they have traveled in the last 14 days, they are symptomatic, or they have been exposed, they have a known exposure to COVID positive patient. So that's the answer on the mental health patient question.
Right.
Pick one.
Okay. I'm not sure what the question is on the right, so I will skip it and I will leave it to Amira. What is the incubation period if you are not sure if you were exposed? So the incubation period, at its longest, is, I believe, still documented at about 12 or 13 days. This is where the 14-day recommendation for asymptomatic people or for people arriving from out of country comes from. So you can think that if there was a potential exposure, 14 days is what we're using as the outside, and that is based on the longest incubation period that has been documented so far. The average incubation period is much shorter than that. The majority of people develop symptoms, if they're going to develop symptoms, at around day 4, anywhere between 3 to 5 days after exposure.
Okay, so I'll take the next one. Staff wearing gloves because of the cuts. Is this reasonable? It costs a lot of worry. So I'm trying to read from here. So no, if you are not having intact hands and are not able to perform hand hygiene, you probably should consider should you be working on or not. If you have a minor cut that can be covered and that you can perform hand hygiene before you put the gloves on, when the gloves are necessary, and perform hand hygiene after you take gloves off when is adequate, you should be working and using gloves and doing hand hygiene normally. If you have any larger sores on your hands and have concerns, please contact your workplace health to ensure that you are followed adequately, because you cannot be using gloves just because you have a cuts on your hands and you would like to protect them. And you won't be really protecting them because prolonged wearing of the gloves causes microorganisms that are normally on your hands, especially if you are not doing the hand hygiene on a regular basis, to grow. So you can make them worse by having the gloves on.
Okay, so the next question, are you saying that you only wear N95 masks if the patient is COVID-19 positive, or as I understand it, for all AGMP? Very good question. As it stands, the use of N95 masks is a strong recommendation for patients that either are COVID-19, that you know are positive, that might be positive, and whether that's because they've had a swab that we're still waiting for the result, or they've even swabbed negative and we're still worried. But if there's still a concern that there could be COVID-19, we're recommending that. We are not recommending the use of N95 masks for all AGMPs across the board. This can be a little bit confusing because there are different recommendations for in the operating room and other places. The general gist and the way to think about this is there are high-risk AGMPs. These are intubations, extubations, and those are the two most common ones that we think of. And in all cases, people are going to be wearing N95s for those. Code blues is another one. Other AGMPs are really up for debate right now. And if people are not falling into that high risk category that I mentioned, we are not recommending that people use N95s. So if someone, say, comes in who has COPD and has broken their ankle and needs, say, BiPAP or needs a nebulizer, we are not saying that that person needs to have an N95 done to give that nebulizer if there is no other clinical risk at this time.
Okay, so the next question is, I'm mammotech. We have to get close to the patient like a hug. Should we wear a gown? No. It all depends what type of mammography you are doing and which area you are working. But in most cases, you are working with the patient that are clean. Currently, if since you are the healthcare workers that is having close contact with the patient, we would suggest using facial protection and keeping your hands clean. But your likelihood of getting something from somebody who is having a mammogram after you have gone through the questions, which everybody now should be going, are you sick before you come in? Your possibilities or risk factors to have something on your clothes, it's on a lower side. And as we suggested, we are suggesting everybody to use your uniforms or your uniforms at work and not while you're going home. So you should be changing your uniform before you go home.
Okay, so I see there are a few questions about disinfectants. I think what we will do is we will save those for next week and focus on questions around PPE at this time. I'm just going to answer the last three questions that I see that are relevant to PPE. So the first is, where is it okay not to wear facial protection? It is okay not to wear facial protection anywhere that is 2 meters from patients that you're involved with patient care. So you can work at the nursing station, go to the cafeteria, break room, etc., without facial protection. The confusion may arise when people wear facial protection for a patient interaction, go to the nursing station, and then anticipate having another patient interaction. Those people will be wearing facial protection in the nursing station, but that is not necessarily required. The areas that we would request people not to wear facial protection are places like the break rooms themselves, the cafeteria, and when you're exiting the hospital.
I'll take one as well. I see my coworker not using PPEs correctly. What should I say or do? This is the time when really we all have to step up and look after ourselves and look after each other. I'm sure your colleagues will not be mad at you if you are kindly offering to help them out and be their officer. That's the new word that we are using right now, and people that are observing each other. We all are going through work in a stressful situation, so having another pair of eyes on looking how people are putting PPs on or taking them off is really helpful. The same thing, I will encourage everybody to address all those people that are walking around the hospital or hallways with the mask dangling down their ear, or the facial sitting up somewhere here holding their long hair. This is not appropriate way of using the PPEs, and we should not be using and reusing PPEs in that way. So please address it, be kind, be nice, like Dr. Bonnie Henry says, but be safe and make everybody around you safe. So let's look after each other.
Okay, so I think we're running to the end of this session. The one thing that I will say is there are a couple of questions here around AGMPs and N95 that I'd like to just address quickly before we stop. The first is, can you clarify that droplet and contact precautions is the right level for suspected and positive COVID patients in non-AGMP? That is correct. So if someone is COVID positive, droplet in contact is adequate and sufficient if there is no AGMP occurring. The other question here is why not N95 mask during testing, since you mentioned possible COVID or confirmed COVID? So I'm not sure, it's hard to interpret the specifics of that question, but I will say that if patients have been tested and you are awaiting the result and that person needs an AGMP in the interim, that person does fall under the category where you would use an N95. Basically, we are not using N95s in patients in whom there is no risk or in patients who have been proven COVID negative. And proven is not just a negative swab, but negative swab and another clear indication and reason for them to be in hospital or to seek clinical care.
So we are running out of time. We will be answering all remaining questions that have arrived, and including the question that we have already answered. We will put them all on our website. You will find our presentation on website as well. Stay safe, Vancouver Coastal Health. We'll see you next Wednesday.